Yes, you're audible.
Good afternoon, everyone. Welcome to our webinar today on the topic Dissemination of Standard Treatment Workflow for Respiratory Disorder. We are honored to have such a distinguished group of experts and participants. Today, the event promises an engaging and enlightening experience for all of us. Let's open our mind and hearts to new ideas as we came together here to learn new facts regarding standard treatment workflow and knowledge. Now, I welcome Dr. Ashu Guggerman. She is Scientist G, Head Delivery Research, ICMR Headquarter, New Delhi. She is the Principal Investigator and Director Clinical Research at Aggarwal University. Dr. Sunita is Ma'am.
Good afternoon, everyone. Thank you, Dr. Shraddha. Conditions. This has been prepared for some of the conditions are
Yes,
in
ma'am. Please
respiratory.
unmute
I'm
yourself,
unmuted.
ma'am.
I'm unmuted, Shraddha. I'm unmuted. Horn mat bajao. Can you hear me, Shraddha?
Yes, ma'am, you are audible, ma'am.
Okay, good. So I will not switch on my video because of
Good
the
afternoon,
poor
Ashu,
background.
ma'am. Can you hear me?
I can hear you, Shraddha. Can you hear me?
My voice is audible to everybody.
Yes, Shraddha, you are audible to us. Yes.
Hello.
Shraddha, you are audible. Yes.
And Pankaj, so am I.
Yes, ma'am, you are also audible, ma'am.
Okay, so
Ma'am.
let us mute Shraddha and I will continue. So these standard treatment workflow are guidance document for the doctors which are working in various levels of care. They are basically one-pager document and they are having everything in one single site. Like it will have start from it is based on, like we had the IMNCI guidelines for the RCH guidelines, and they were very effective for the doctors. So when they were trying to become very effective, so we thought that why not to have some standards of care for all conditions to be there. So we developed STW for around 23 specialities, wherein 157 standard treatment workflows have been prepared so far. So for dissemination or making the wider reach of STWs to all the doctors, to all the faculty and maybe primary, secondary or tertiary levels of care, ministry now has been very kind enough that these standards of care should be extended across different parts in the country. So that is how we have started having these webinars, and these webinars are being done from the government level, from the ministry side, and we have already done two such webinars in the area of endocrinology and in the area of oncology. So today's webinar is focusing on respiratory disorders. These respiratory disorders standard treatment workflow were prepared in consultation with all the eminent respiratory experts, the public health experts, and some at the district level experts were also there. So they are focusing on common conditions like asthma, chronic obstructive pulmonary disease, respiratory failure, acute respiratory infections. And these experts are there with all of you today. And they will be talking about each and every, these conditions one by one. And idea behind disseminating this standard treatment workflow is that there should be some minimum standards which should be followed by doctors at any level of care. For example, for asthma, various drug combinations are available. So how to diagnose these conditions as early so that we can have this management and the diagnosis um, at an appropriate level of care, and what drugs to be given, what doses to be given. So everything has been mentioned into that STW. Now, as far as the dissemination part is concerned, we recommend and we suggest that they can be definitely printed and put up on the OPD or IPD setting wherever you people are working. And they're equally important for the private doctors as well. So the whole aim of having this STW is to have a standards of care, number one. Number two, to minimize the investigations load. And third, to have a referral systems and to strengthen the referral mechanism that can be done at a primary level. So why we should go to the tertiary level? So they are in sync with the Indian public health standards also. And this their chart, they do mention what a doctor at a primary level, at secondary and tertiary and a higher center should be done. Another feature is it has the red flag signs when to refer the patient to a higher center and when to have an immediate prompt action. So all those details have been mentioned into the one standard treatment workflow, which is a very concise one-page document. It is available on the web form. It is available on the app form also. This can be downloadable. We can put it on your mobile application. So these are the some salient features. So for this respiratory condition webinar, I really welcome Dr. Khilnani, Dr. Dhruv, Dr. S.C. Jindal, Dr. Ashutosh, who are quite experts in the field of their pulmonology. So over to you, Dr. Shraddha, to have more feedback and more sessions from the eminent experts we are having today for this webinar. And don't forget to give the feedback form, which will be given to you at the end of the survey, or maybe it can be given in the middle of the webinar as well. Thank you, and over to you, Shraddha.
Thank you, ma'am. Thank you, ma'am.
Yes, please go ahead.
Yes. Now, as Sunita Sharma, ma'am, Director DGHS, Ministry of Health and Family Welfare, Government of India, she is busy in some meeting, and along with Dr. Swasticharan, sir. So I request Professor Dr. Surendra K. Jindal, sir. He is Emeritus Professor, Postgraduate Institute of Medical Education and Research, Chandigarh. He is the chairperson of this standard treatment workflow for pulmonology and respiratory diseases. So, sir, please give some opening remarks and some view of the significance and importance of standard treatment workflow for respiratory disorders. Please, sir.
Okay, thank you very much. I think the subject has already been introduced by Dr. Ashu Grover. These standard treatment workflows or guidelines, you see, is an ICMR and Department of Health Research initiative, which were taken almost now 8 to 10 years ago. And respiratory diseases, of course, form an important component of these guidelines because of there's a lot of heterogeneity of treatment at different levels of healthcare in this country. And the purpose is to make it uniform as far as possible and make it cost effective, affordable, and available to all. See, but still we do not want to lose the evidence for a particular recommendation. So I think a group of several experts had sat down in 2018, I suppose, late 2018s, as far as respiratory diseases are concerned. And we chose 4 main groups, you see: asthma, COPD, respiratory infections, and of course, respiratory failure. And each group had few members who discussed in detail, and we have advisory people, advisory committee, etc. So finally, I think the documents were prepared. They have stood the test of time for last several years. It is likely that more conditions may be now included and some modifications may have taken place, but the basic principle or premise remains the same, you see, as far as treatment is concerned. Obviously, there always standard treatment guidelines are slightly, you can say, a diluted version of the evidence-based guidelines, which are so rigid, you see, that you generally become unavailable to everyone, you see. So the standard treatment guidelines do not lose the scientific content, yet they're practical, I think, and feasible at the primary care level as well. Of course, depending upon the level of illness, they may also be practiced at secondary and tertiary care, where the treatment lines may differ depending upon the underlying condition. So we have a group of very eminent and experienced clinicians here, Professor Khilnani, Professor Dhruv Chaudhary, and Professor Ashutosh Aggarwal, who are here to discuss the different issues. And I'll also take over the COPD component. So first of all, I think I'll request Dr. Gurha to kindly welcome the next speaker for the guidelines. Thank you.
Thank you so much, sir, for the valuable remark. Now I request Professor Dr. Khilnani, sir. He is a Chairman PSRI and a former head and professor of Department of Pulmonary Medicine and Sleep Disorder, AIIMS, New Delhi. Sir will speak on acute respiratory infections. Welcome, sir.
So, good afternoon, ladies and gentlemen. Am I audible?
Yes, sir.
Respected Professor Jindal, who has been like my teacher and more than teacher and mentor in so many ways. Thanks to ICMR for organizing this meeting along with Ministry of Health. Now, lower respiratory tract infections are very important, and so much so that father of medicine, as William Osler called pneumonia as captain of men of death. Not only the pulmonologists see pneumonia, but every physician, every doctor practicing at whatever level, be it primary health center or even at sub-center level, would see lower respiratory tract infection. A study conducted at Pune on a large number of thousands of practitioners revealed that 50% of the all patients seeking medical attention actually had respiratory illness. So this particular presentation is based on the module which has already been created, and my job is to elaborate on that. The purpose is that person practicing at whatever level he is, every patient should get optimum care. Every patient should be referred at a proper time. Every patient should be properly investigated, and every patient should get appropriate treatment. As we all know, that respiratory tract is involves the upper respiratory tract and lower respiratory tract, so both will be covered. So we will be discussing outpatient as well as inpatient care, and this module has been prepared, as Dr. Jindal has said, that by top experts of this country. And so I'll straight away, without wasting time, will go to the when do you suspect respiratory tract infection? When to suspect? Patient goes to the doctor. The most common symptom of respiratory tract infection is cough. Usually it is with expectoration, which can be yellow or rusty sputum. Classically, as we have learned in our medicine MBBS course, a rusty sputum, although we rarely see this nowadays because of use of antibiotics. There can be breathlessness, there can be pleuritic chest pain, there can be malaise or myalgia or body ache, there can be joint pains at times without swelling, and there would be some extra pulmonary symptoms also. When you take a history, it is important to ask a past history of tuberculosis, history of pneumonia, history of airway disease. Like so many patients have asthma, 5 to 10% of the world population has asthma. COPD is so common. So it is important that we should ask whether person is already suffering. Diabetes is important because diabetics are some way immunocompromised, and also chronic steroid use and any other immunocompromising condition, which could be connective tissue disease or some patient on chemotherapy or he's taking some drugs which are
Excuse me,
used
sir,
for.
Dr. Khilnani, sir. I'm just interrupting in between Dr. Ashu here. Are you sharing your STW or should we share from our end, sir?
No, I'm sharing my slide. Is it not seen?
No, sir, they are not seen, sir. That is how
Okay.
I'm sorry for
Okay.
interruption, sir.
Wait a minute. My slides are seen now.
Yes, sir. Yes, sir. Please make it slideshow.
Is it okay now? Are my slides seen?
Yes, sir.
Okay, all right. I'm sorry about. So I'll start from the beginning. Sorry about. So introducing my
Yeah,
this
you
thing.
can quickly go through, sir.
Yeah, sure. I'll do that. So without emphasizing the importance of this, which I have already said, whenever the patient comes to a physician and how to suspect that patient has got respiratory infection, the cardinal symptoms are cough, breathlessness, pleuritic chest pain, myalgia and extrapulmonary symptoms. At the same time, it is important to ask about previous illness of tuberculosis, pneumonia, airway disease like asthma, bronchiectasis, diabetes, and steroid use. Now, as soon as the patient comes, it is very important to find out whether this patient can be managed in your outpatient setting or you need to, or this patient is in respiratory failure, must be referred to the higher center for emergency care. So vital signs are extremely important. Now, most important is sensorium. You never forget to examine the pulse. The heart rate is very important. Blood pressure is important. The respiratory rate important. Temperature should be measured. Nowadays, the oxygen saturation probe is available with everybody. So pulse oximetry has become part of physical examination. At the same time, as soon as you see the patient, you examine the upper respiratory tract, also sinuses, and also examine the upper respiratory tract. Look at the nasal mucosa, examine the respiratory system, and also in the form of whether there are bronchial breath sounds or there are crepitation or there are wheezing or pleural rub or there are features of pleural effusion. It is important to point out here that in the history, if there is hemoptysis, this takes you towards tuberculosis or malignancy, or although the pneumonia, there can be hemoptysis, it can be in pulmonary embolism, and there are so many other diseases, but most common remain tuberculosis, bronchiectasis, and malignancy. Now, it is important to emphasize here that no patient should be denied referral to the proper center because, as I said at the outset, that respiratory infections are major killers. all over the world, not only in India. So signs of respiratory failure, which are given in red, that is if the respiratory rate is more than 30, or if there is abdominal paradox is there, that means the accessory muscles of respiration are working. If the patient is blue, if there is a cyanosis, or patient is unable to speak a short sentence without breaking a breath, that, or if there is a, your oxygen saturation probe is showing oxygen saturation of less than 90, that means 90%. That means this patient is in respiratory failure and he must be referred to a higher center after giving a preliminary treatment, which I'll be talking about. Now, then we proceed for further assessment. Look at the fever, look at the tachycardia, look at the pharyngitis, look at the suffusion of the eye, look at the, examine the nose, look at the voice, and if the respiratory system is examination normal, possibly this patient has an upper respiratory tract involvement. Or if there is a fever, or respiratory, if there is a tachycardia, you have to ask about whether this patient has asthma. If there is a fever, tachycardia, respiratory, the, if the breath sound, respiratory rate is high, consider acute exacerbation. If there is a history of any previous history of asthma, COPD, and I would also add interstitial lung disease. Now I'll be discussing about pathways, how to assess these things one by one. So the pathway one, if there is upper respiratory tract infection is there, then one should do a total and differential counts in suspected flu, because if the counts are high, this is likely to be bacterial. But you, till the time you get the reports, you have to treat the symptomatic treatment by giving paracetamol or other NSAIDs. My choice would be paracetamol. Hydration is very important. Person take plenty of fluids. Oral antihistaminics can be given. It could be chlorpheniramine maleate, 4 milligram twice a day, and long-acting antihistaminics are also nowadays available, like levocetirizine or fexofenadine. Antibiotics in acute, if you see the tonsils are enlarged, and if you see the pus point, that means this patient has tonsillitis, then amoxicillin or ampicillin, 500 milligram, 3 times a day is a drug of choice. Erythromycin is not so well available, but erythromycin is a macrolide, and longer acting macrolides are also available. And the flu should be suspected if there is an outbreak of flu at that particular point of time, that one should be careful. The pathway two is when there is a lower respiratory tract involved. That means there is a bronchitis. Bronchitis means bronchial inflammation. So that requires total and differential counts if the sputum is purulent. X-ray chest is an essential part of when you are suspecting lower respiratory tract infection. The treatment is besides symptomatic as paracetamol and oral fluid. Inhaled bronchodilators like salbutamol is given in a nebulization or in a MDI form every 6 to 8 hourly. Antibiotics if there is a purulent sputum. Purulent sputum means yellow or green or foul smelling sputum. The mucoid non-infective sputum is whitish and thin. And if there is a leukocytosis on blood examination, that also requires antibiotics in the form of amoxicillin, 500 milligram, 3 times a day for 5 days. Or if the patient is penicillin sensitive, a macrolide can be given. If the patient is known asthmatic or if he has severe bronchospasm, then he should be referred to the asthma module, which is discussed elsewhere. Now, if the patient has pneumonia, so it is important to decide whether this pneumonia can be treated on the patient of outpatient, or this patient should be admitted to the hospital, or this patient should be admitted in the ICU. Because as I said at the outset, pneumonia is one of the biggest killer, as we saw in the COVID time also. So there's a simplified score is there, CRB 65, that is level of consciousness and respiratory rate. The actual score was curved, out of which urea has been removed. So if the score is 3 to 4, that is high risk. This patient is likely to require ICU. The B stands for blood pressure. That is mean blood pressure of less than 65, and curve 65 is the age. If the age is more than 65, so you give 1 for each point. So if the score is 3 to 4, this patient is likely to require ICU care. If it is 1 to 2, is likely to require inpatient. If the score is 0, that means if the patient is young, his blood pressure is normal, his respiratory rate is normal, and he is conscious, he can be managed in the ICU, in the outpatient setting. Now, what investigation to do? If the curve score is 0 to 1, you can do a chest X-ray. If there is a worsening, you can repeat it. If you are suspecting underlying malignancy, then of course the further investigation should be done. If the tuberculosis is suspected, then you have to do a sputum examination for smear and gene expert while giving antibiotics. Now, what should be the treatment? As we all know, the commonest bacteria which causes pneumonia remains Streptococcus pneumoniae. Oral antibiotics are preferred in the outpatient, but it is important to consider whether this patient has diabetes or cardiovascular disease or CKD or chronic liver disease or any other chronic disease, cancer, alcohol abuse, or history of antibiotic in the past 3 months. Why I am telling you all this? Because in that case, your antibiotic choice, initial antibiotic choice would change. You can give amoxicillin along with doxycycline would be a drug of choice. We do not use quinolones in pneumonia in India because tuberculosis is endemic, and we reserve quinolones for tuberculosis, and it increases the chances of resistance. It also increases the chances of missing the diagnosis. So therefore, whenever there are comorbidities along with pneumonia, even if the patient does not require admission, then you have to give 2 antibiotics and avoid using quinolones. If you are constrained to use quinolones, then you must rule out tuberculosis by sending sputa for examination. Now, inpatient management of pneumonia is different. You can treat with single agent with intravenous beta-lactam antibiotics. Now, if you suspect atypical pathogen, other and organ disease, or as I said, diabetes or antibiotic use in a prior 3 months, or the person has coexisting lung disease or has diabetes, or is immunocompromised because of any accord, CKD, or then you have to give a combination therapy. Now, antibiotic therapy in hospitalized setting, you also have to consider whether there is any risk factor for pseudomonas. And these risk factors are diabetes, chronic lung disease like bronchitis, or any other structural lung disease. Then you have to give antibiotics which are empirical antibiotics which are good for pseudomonas. And these include cefepime, ceftazidime, piperacillin, tazobactam, and other. And whenever you are treating pseudomonas, you have to give 2 antibiotics instead of 1. Now, are there any adjunctive therapy? As per the guidelines goes, the steroids are not recommended for use in non-severe care. So, if the person is in the outpatient or even an inpatient, if his blood pressure is normal and he is not requiring oxygen, then steroid should not be used. However, on the other hand, other adjunctive therapy, non-invasive ventilation may be used in patients with CAP and acute respiratory failure till the time the patient is shifted to the ICU. Now, this is very important, and one should also realize what are the contraindication to non-invasive ventilation if there is a cardiorespiratory arrest, if there is upper airway inflammation, if there is a deformity of the oral cavity or person is edentulous, or there is severe hemodynamic instability like hypotension, if there is a altered level of consciousness, or there is multiple organ dysfunction, which all these require uh, invasive mechanical ventilation where the NIV actually may be harmful. Now the patient after he recovers, after the fever improves, and the discharge should be decided based on the clinical, not based on the radiology or other investigation. Now, when to refer to the high center? And this is extremely important because, as I said at the outset, no patient should die. One is frank hemoptysis or signs of respiratory failure, which I have already described. If the CRB score is more than 1, which I have already described, if the oxygen saturation by pulse oximetry is less than 92%, or the blood or the saturation and patient is old, multilobar consolidation on X-ray, if the patient's level of consciousness is altered, or there is hypothermia, that is if the core temperature is less than 360 degree, then patient should be. Now points to note while shifting. It is very important that patient should be shifted safely to the hospital. If referring to a higher center, give the first dose of antibiotic, oral and if available parenteral. This is extremely important. Secure an intravenous line and start 0.9% normal saline for hydration. Give oxygen supplementation through face mask at 4 to 6 liter or at a rate as so as to maintain the SpO2 of more than 90% during shifting. If the patient is drowsy, has copious secretion, consider calling for help from sub-district or district hospital for endotracheal intubation and shifting on a transport ventilator. Now, this is all about, I wanted to say 15 minutes granted to me. I might have missed few things which I would like to say because pneumonia is extremely big subject, but I will be most happy to answer any questions. If any. Thank you very much. Thank you, ICMR and Department of Health.
Thank you, sir. Thank you, sir, for the wonderful presentation on standard treatment workflow for acute respiratory infections. Now I request Dr. Ashutosh Aggarwal, sir, to speak up on standard treatment workflow of asthma. He is from Postgraduate Institute of Medical Education and Research Center, Chandigarh, and he is expert of our standard treatment workflow project of ICMR as well. Welcome, sir.
Thank you, Dr. Shraddha. Am I audible?
Yes, sir.
Okay. Thank you, Dr. Ashutosh and the entire team for this opportunity. As Dr. Jindal and Dr. Khilnani have already pointed out, the standard treatment workflows help to set a kind of minimum benchmark about the facilities, the processes, and the protocols that should be uniformly applied to patients who come with various diseases to primary and secondary levels of healthcare. Today, I'll be briefly discussing the asthma standard treatment workflow. Let me just share my slides. Are my slides visible?
Yes, sir.
Okay, so bronchial asthma, as we all know, is a common respiratory disorder that presents not just to pulmonary physicians, but to almost anyone who is practicing medicine or allied specialties, and sometimes even to other specialties. It's important to recognize it and manage it adequately, because in the long run, it is associated with the impairment of quality of life and other complications that can be easily avoided if the treatment is started on time and the patients continue to take treatment. So asthma often will present with recurrent episodes of wheezing, breathlessness, cough, and or chest tightness. These symptoms are sometimes non-specific, and you may have only one or more of these symptoms. So it is always important to have a high index of suspicion when we are dealing with patients who come with such symptoms. If you suspect asthma, then you can also inquire about some of the other supportive features. For instance, if the patient has a history of atopic features like allergic rhinitis or skin allergies and or hay fever or conjunctivitis, or if the patient has a family history of asthma, if the patient can identify some triggers which lead to these symptoms, for instance, dust exposure or seasonal changes and or some smells or some other allergens. And on examination, if you are able to detect the presence of bronchospasm, then all these will support the diagnosis of asthma. More importantly, there should not be any alternative explanation for these symptoms. Because these symptoms are non-specific, sometimes other disorders can also manifest with similar presentation, and it is important to rule these out before we really start on treating patients as an asthma. So some of the important things that we must exclude are, one, obviously, is chronic obstructive pulmonary disease, which is the other common obstructive airway disorder that we encounter commonly in our clinical practice. So we have to identify features that will favor asthma over COPD or COPD over asthma before we make a provisional diagnosis of either of the two. And I will shortly cover some of the basic clinical features that can easily be found on an OPD basis that will help in this regard. Then other mimics also need to be ruled out, and some of these mimics will have other ancillary symptoms apart from the symptoms that I have already mentioned. For instance, if there is presence of fever, or if there are significant constitutional features, if the patient is having expectoration but the sputum is purulent, or if the patient is having hemoptysis, or if on examination we find focal chest signs, for instance, presence of any bronchial breathing or some focal area of crepitations, then these are features that will take us away from a primary diagnosis of asthma. If the patient has a chest X-ray, then that can also be evaluated. Normally, asthma patients should have a normal or a near normal chest radiograph. But if you again find some abnormalities, especially focal findings, then asthma is not a likely differential in this scenario. But the common thing that we need to distinguish asthma from is COPD, and the two are different disorders. Although they might be treated with a similar kind of medications, they have a entirely different kind of prognosis. And it is important, therefore, to distinguish between the two, not only to determine what kind of initial treatment is required, but also to explain the overall prognosis to patients and their family. So asthma, in contrast to COPD, usually presents in early adulthood or even in childhood, and but the age of onset could be variable. COPD usually presents later in life, usually around the fourth or the fifth decade, or sometimes even later. So younger patients are more likely to have asthma, while older patients are more likely to have COPD. The symptoms are usually episodic in asthma. So you have periods of symptoms, and in between the patient might be completely normal and symptom free. Whereas in COPD patients, the symptoms are usually progressive over a period of time. there may not be any good days for the patient in between. COPD patients also have a common exposure history, mostly related to smoking, either active or passive, or even other exposures such as exposure to biomass fuel combustion at home, or air pollution and so on. Whereas some of these exposures are distinctly uncommon in patients with asthma. Again, as I mentioned, atopic symptoms are much more common in asthma in contrast to COPD. Often asthma patients will also report some family members who have similar disease. And usually patients can also identify some triggers that cause worsening of symptoms. These things are less common in patients with COPD. On examination, wheeze is almost universal and a prominent feature of physical examination in patients with asthma, especially if they present to you in a phase of symptoms. In between, when the symptoms are absent, at those times, the chest auscultation can be completely normal. COPD patients, in contrast, may or may not have a wheeze. It is more important to have confirm it by the progressive nature of the respiratory symptoms rather than just by the presence or absence of wheeze. So, in short, I would say that the diagnosis of asthma, therefore, is largely clinical. It is based on what kind of symptoms the patient has, what is the progression of the symptoms, what is the periodicity of the symptoms, and whether or not there are associated atopic features or family history. And if one or more of these are present, then it might be a good idea to make a clinical diagnosis of bronchial asthma. You can always support it with investigations by documenting a variable airflow limitation. So you can do a spirometry if it is available. The international guidelines will suggest that a spirometry should be performed for all patients. So on spirometry, you can document airway obstruction, and then you can give a short-acting bronchodilator and repeat the pulmonary function testing and see if there is substantial improvement in lung function. Whenever there is a doubt in the diagnosis, or you are not exactly able to say whether this is asthma or some other disorder, then these patients could be referred to a higher center for further workup if the diagnosis cannot be made at the current level of healthcare. So once you have made a provisional diagnosis of asthma or even confirmed it with spirometry and by ruling out some of the other asthma mimics, you would want to initiate therapy. Currently, the inhaled drugs are the mainstay of therapy. Oral drugs are generally avoided because they have a poorer safety profile and require much higher doses to achieve the same kind of benefit. Unfortunately, in several parts of the country, inhaled drugs are still either not available or are considered as a taboo. And even if you prescribe them, patients don't take. I think over the last few years, this kind of mindset has been changing, but it is important to emphasize that inhaled drugs should be the ideal treatment modality. And we would like to initiate treatment based on the frequency of symptoms. If the frequency of symptoms is less, patients require a lesser kind of therapy. And if the frequency of symptoms is more, they may require more drugs or more frequent administration of drugs. Whatever treatment we initiate, we should be reassessing these patients at 3 to 4 weeks interval. And a good response to appropriate inhaler therapy is sometimes useful in confirming the asthma diagnosis because it goes in with the variable nature of this disease. Apart from pharmacotherapy, there is always a strong emphasis on patient education. So patients should be educated on several aspects, the most important of which is the need for continued therapy. Because asthma is associated with intermittent symptoms and often responds very well to inhaler therapy, a lot of patients will skip treatment once the symptoms improve, without realizing that once they stop therapy, then over the next few days or weeks, the symptoms will return and the inflammation will restart. So this is important. Inhaler technique is something that we always insist. You should check if the patient is taking the inhaler properly. If not, teach. If the patient cannot learn or is having difficulty, then maybe we need to change the inhaler device so that he can take it properly. For some educated patients, we can also prescribe home peak expiratory flow monitoring wherever feasible, and this sometimes can help in picking up exacerbations early. And simultaneously, patients should also be told about warning signs when they need to escalate treatment or visit a physician in between. And also some plan for hiking up treatment in case of symptom worsening. Side by side, they should also be told how they can avoid possible triggers depending on what triggers bother them. So even in follow-up, we need to check inhaler technique at each visit and inquire about treatment compliance. For follow-up visits, we need to assess disease control, and I will just shortly highlight how we check on disease control. And based on whether the disease control is adequate or inadequate, we can step up or step down the treatment based on this. And this disease control is based on very simple clinical parameters, does not require any major investigations. Most patients can be followed up at a 3-monthly interval once their treatment has been kind of regulated and fixed, but they can modulate the therapy as and when required. And if despite optimization of treatment, if asthma remains poorly controlled, then these patients should be referred to a higher center for further evaluation and management as appropriate. So this is how we assess asthma control. Normally, if patient has daytime symptoms or needs a rescue inhaler dose more than twice in a week, or if the patient complains of any nighttime symptoms or nocturnal awakening, or if the patient is limited in his or her activities due to the asthma symptoms, then this patient is not adequately controlled and will require stepping up of treatment or trying to find out why the asthma is not well controlled. Maybe he's not taking the inhalers properly. You can also do a lung function testing if it is available, and persistently low lung function testing test results, despite an optimized treatment regimen, again will point to a poorly controlled disease. So this is the broad treatment algorithm that we should be following. If for patients who have infrequent and intermittent symptoms, and SOS use of a short-acting beta agonist like a levosalbutamol, 2 puffs taken as the basis is sufficient. For patients with regular symptoms, which means less than twice per week, but more than twice per month. So these are milder kind of infrequent but regular. So these patients can be managed with low dose inhaled steroids, such as budesonide, 100 micrograms, 2 puffs twice daily. Plus you can add a short acting beta agonist like levosalbutamol to be taken on a SOS basis. On the other hand, if the patient has regular symptoms, which means symptoms occur more than twice per week, or if the patient has reported an exacerbation in the last 1 year, then these patients should be put on a combination of inhaled corticosteroids and a long-acting beta agonist. The long-acting beta agonist that we prefer is formoterol. It is advantageous because it is long-acting plus has a quick onset of action. So this combination can be taken both as a reliever as well as a maintenance drug. For maintenance, we would suggest that 2 puffs of this combination can be taken twice daily. And for reliever dose, additional puffs can be taken of the same inhaler if the patient has breakthrough symptoms. At any stage, if you find that the symptoms are poorly controlled, and we have just discussed how control can be assessed, then the treatment can be escalated to the next level. If the patients are inadequately controlled on the standard dosing of inhaled corticosteroid and long-acting beta agonist combination, then we can also add tiotropium to the treatment. So tiotropium is prescribed again as an inhaler, which is 9 micrograms per dose, 2 puffs once a day. Alternatively, we can add low-dose oral methylxanthine such as aminophylline or terifylline if the tiotropium inhaler is not available. At any point, if the control is optimized and the patient remains symptom-free for 3 months or more, then we can try stepping down to the previous level. And ultimately, this cycle will go on either escalation or de-escalation till we have reached a dose, the minimum possible dose at which the patient derives maximum benefit and control of the disease. At any point, if the patient, despite proper inhaled therapy, is not having sufficient control, then you might decide to refer these patients to a higher center for further assessment. For some of these patients, we can also add low-dose oral corticosteroids as the last resort. But in general, a referral at this point is preferred. In between, the asthma patients will have disease exacerbations, which are episodes of acute symptomatic worsening. Or if the patient is performing low peak expiratory flow monitoring, then reduction to in peak expiratory flow to 80% of personal best while the patient is on continued treatment. So if such symptomatic worsening occurs, then the patient can be advised to take 2 additional puffs of the inhaler being used. If the patient is using a combination inhaler, then the same inhaler can be taken. If the patient is using only SOS inhaler or just an inhaled corticosteroid, then a short-acting beta agonist like levosalbutamol can be prescribed. If the patient shows no response during this particular day, or if the symptoms progressively worsening, or if the peak expiratory flow further reduces, then home remedy is not the answer. Patients should contact their physician on the earliest opportunity. Once the patients present to a physician, then you can assess for exacerbation severity and manage these patients accordingly. So if the patients come to you in exacerbation after having taken their extra doses and not finding any response, the first thing that you will need to decide is whether the patient is sick enough to be hospitalized, or can this patient be managed on an outpatient basis. So there are several important clinical parameters that one can easily assess, which will indicate the need for hospitalization and inpatient treatment. For instance, if the patient is so breathless that he is unable to complete sentences, or if the patient looks agitated, if on examination you find that there is significant use of accessory muscles of respiration, if the patient has tachypnea or tachycardia, or sometimes in severe exacerbations, you can also record a pulsus paradoxus, which is the difference in the systolic blood pressure between inspiration and expiration. Then this is a sign of severe acute asthma. On auscultation, if you find a silent chest, so if there is bronchospasm, then it is good. If the bronchospasm is so severe that the air entry is substantially reduced, then paradoxically the chest might be completely silent with very reduced air entry. Oximeters are now commonly available. If the patient has rheumier hypoxemia, then also this is an indication that patient requires inpatient treatment. So if these patients are admitted, if the facilities are available for admission, hospitalization at that level of healthcare, then these patients should be started on oxygen supplementation to maintain a pulse oximetric saturation between 92 to 95%. You can augment the ongoing therapy with nebulizations of short-acting beta agonist and the anti-muscarinic agent. So normally we nebulize a mixture of levosalbutamol and ipratropium. Both of these are short-acting agents. So 3 doses can be nebulized at 20 minutes interval, and then depending on improvement, we can re-escalate to 4 to 6 hourly dose or as needed basis. Acute exacerbations also require systemic corticosteroids. So for hospitalized patients, we can give the initial dose intravenously as a hydrocortisone 200 milligram injection, and then follow up with the oral prednisone 0.5 mg per kg per day if the patient is able to take orally for the next 5 days. At any point, if you feel that the patient is not improving, then refer to the next level of healthcare. If the patient does improve, then you discharge only when there is complete symptom resolution. The wheezing is either absent or is substantially reduced. The tachycardia and the tachypnea have settled down, and the room air oxygen saturation is within an acceptably normal range. Even at home, the patient should be instructed to continue oral prednisolone in the same dose for a total of 7 days and continue their rescue medication, the additional inhaler doses as per their requirement. At this point, before even at the time of discharge, you should schedule a follow-up visit on an outpatient basis 1 week from discharge, and patients can be followed at their usual level of healthcare, which is in most instances the primary healthcare. Sometimes these patients will also give you some red flag signs which point towards a life-threatening exacerbation, which is even a very severe form of exacerbation. So if these patients have some alteration in sensorium, if they are orthopneic, if they manifest with frank cyanosis, or if they have paradoxical breathing, if they are in hypotension, or if they have bradycardia instead of tachycardia, then these are signs of impending respiratory failure and signify a life-threatening exacerbation. These patients cannot be usually managed on a simple outpatient, inpatient basis and will require ICU facilities. So if ICU facilities do not exist at that level of healthcare, then these patients should be immediately referred while you provide facilities for oxygen supplementation, nebulization, etc. on during the phase of transport. Other patients who do not have these kind of manifestations are non-severe exacerbations, and these patients can be managed on an outpatient basis very easily. So you will continue the additional inhaler doses as per patient requirement and start on oral prednisolone 0.5 mg per kg or its equivalent once daily for a short duration of only about 5 days. Again, schedule follow-up outpatient visit at 1 week interval to check whether the patient has responded or not. So this is in brief, I had to discuss about how asthma can be diagnosed and managed at the primary and secondary levels of healthcare. Thank you for your attention.
Thank you, sir. Thank you, sir. Now I request Professor Dr. Surendra K. Jindal, sir. He is Emeritus Professor, Postgraduate Institute of Medical Education and Research, Chandigarh. He will speak on standard treatment workflow of chronic obstructive pulmonary disease. Welcome, sir.
Thank you very much for inviting me to this useful talk, meaningful talk for the doctors in general. Can you share my slides? You have the presentation. But the subject I'm going to talk about STWs in COPD has been already partly introduced by Professor Ashutosh Aggarwal, I think, because there is a lot of confusion between asthma and COPD, both regarding the terminology, the diagnosis, and also treatment, you see. There's a lot of overlap, I would say. By and large, both are called as dama or by equivalent terms in the Indian languages all over the country, you see. That causes confusion, both for the general public as well as the doctors, you see. Now, what is COPD? It's chronic obstructive pulmonary disease, which in the beginning was called separately chronic bronchitis, emphysema, etc. And various terms have been used over the next few decades. But presently, by and large, the consensus is to call it as COPD, collectively. So it's a kind of collective term for airway obstruction, which is progressive, unlike asthma, which responds to treatment. COPD also responds to treatment, but not completely, you see. And by and large, it is a progressive disease, subsequently leading on to different kind of combinations. Yes, Shraddha, can you show the slides, Shraddha?
Yes, sir. Please.
Well, of course, the commonest symptom with which these patients will come is breathlessness, cough, and with or without sputum production, you see. So sometimes it becomes difficult to diagnose whether it is asthma, COPD, or some other conditions, you see, because sometimes even infections, tuberculosis can also present with similar symptoms. So by and large, the differentiating points have been mentioned earlier. One important is the age. Asthma generally starts in early age, in childhood or in teenage, while COPD is a late age disease in the middle age or older age, commonly seen in smokers or those people who are exposed to other kind of pollutants, like even kind of household domestic smoke due to biomass fuels burning. And of course, the industrial exposures may also cause, and outdoor pollution can also cause COPD. See. Now, the question is how to define COPD. It is a kind of chronic dose. Initially, you will remember it was called as a
good evening, sir. The screens are not visible, sir.
I think they are to be shared by.
They have written that STW team has started screen sharing, but not visible.
It is
Dr.
not.
Shraddha, can you please check it, Ashu?
It is not visible to me either. You see.
Yeah, not visible to me also, sir.
Shraddha, please do that.
Uh, Dr. Shraddha?
Yeah, now I think it is, everybody can appreciate the slides. Am I audible?
Yes. Now they are visible now, please.
Because of some network.
Yeah, please go ahead, you see.
Sorry for the inconvenience.
Yeah, go to the next. I can't change it perhaps from here. All right. So how to really go ahead with the diagnosis? By and large, the patient will come with symptoms rather than the diagnosis. I think that is one common issue which doctors face. So patient presenting with breathlessness, wheezing, chest tightness, cough and or sputum production. So one can follow, or that either kind of arm for the diagnosis. Detailed history, of course, is to be taken, risk factors, triggers, relevant physical examination. So if these are suggestive, then it could be probable asthma or COPD. At this stage, you see, one would like to do spirometry, because for diagnosis of COPD, a spirometric demonstration of airway obstruction is important, you see. And one should also see the disease control, because many patients may have been taking some treatment, etc. One has to also see whether there's any other alternate diagnosis, because these symptoms, especially of breathlessness, can be commonly caused by heart disease and some other problems, heart disease in particular. So that should be excluded. Similarly, on the right-hand side, you can see the third arm of the algorithm. If sputum is present for more than 2 weeks, you see, then as per as the national tuberculosis guidelines, especially in this country, it should be examined for acid-fast bacilli, because tuberculosis should always be suspected in a new patient coming with the cough of short duration. See. But otherwise, the straight middle kind of algorithm or the flow should be followed for the diagnosis for most of these symptoms, most of these patients. You see. Next, please. Can you go to the next? So we suspect COPD whenever the age is more than 35 years, risk factors are present, symptoms are present, and then there are sportive features like hyperinflation of chest, you see, barrel-shaped chest. This may not be a common finding these days because this usually is seen in the later stages of the illness. Hyperresonant note on chest percussion, diminished breath sound. So all these signs typically of emphysema, they may be seen, but in early stages, they may not be present. And if we do not find any alternative explanation of these symptoms, then we suspect a COPD. See. Next. And what other conditions to exclude? I have already said that the other causes of breathlessness or cough should be excluded, in particular asthma, and the points we have already discussed earlier. Tuberculosis should be excluded, and maybe other mimics sometimes, which can cause fever, hemoptysis, orthopnea, chest pain, etc. So all these things should be excluded because they are important for the differential diagnosis of breathlessness and chronic cough. You see. Next. How to assess the severity and confirm the diagnosis? The airway obstruction should always be documented on spirometry. And nowadays, it is easily available at even primary care levels at most places in this country, and different kinds of spirometers may be available. Although one should not totally depend upon spirometric demonstration, but it is a kind of corroborative finding, you see. The diagnosis should be supported by spirometric demonstration of airway obstruction. And the post-bronchodilator FV1 over FVC ratio, if it is diminished less than 70%, it defines airway obstruction. Again, we are not going into the details of spirometric interpretation. And then based on the spirometry and the severity of dyspnea, which is measured with the help of modified MRC scale, exacerbation frequency, and any presence of comorbidities, you see, the treatment is further decided. There are a lot of kind of recommendations regarding treatment, but we will discuss only the simplified kind of management which should be done. Next. Now, how to initiate the treatment? I think it is important to know whether it is asthma or COPD or anything else, you see, any other cause like congestive heart failure or interstitial lung disease or so on, you see. How bad is the disease, the symptoms, the spirometry, and which drugs are likely to be most effective, which inhaler device is most suitable for the patient, because that may depend upon several factors, such as patient preferences, whether it is a rotahaler, and what are the disease characteristics, the cost of the inhalers and other treatments, the availability, and then, of course, the patient's understanding. You see, the training and demonstration are important. We'll come to this point very soon. You see. Next. And generally, that's the standard categorization of severity. As I said earlier, it is done with the help of spirometry and the degree of breathlessness, the presence of exacerbations or other complications. And normally we say it's mild, moderate, and severe COPD. See. Based on spirometric values, if FEV1 is more than 80%, and of course the ratio is less than 70. That is an essential criteria for all COPD, you see. And dyspnea is only 0 to 1 exacerbation and no complication. It is mild, you see, kind of COPD, which can be easily handled. But then it could be moderate when there is more severe dyspnea of 2 to 4 MRC categorization, presence of one exacerbations, at least 0 to 1 exacerbation, and low FEV1 over low FEV1. See. And if FEV1 is very low, less than 50%, then of course it is severe. The dyspnea is also severe here, 2 to 4 grade MMRC. And there are more exacerbations, generally more than 2 per year, you see. And if there are complications. And it is normally said that the category with worst value is used to assign severity. That is important because that is important for patient's treatment. And complications may include respiratory failure if the SpO2 is low, less than 88%, or the partial pressure of oxygen is less than 60, you see. Or there is cor pulmonale, like pulmonary hypertension, secondary polycythemia, and so on. You see. So all these complications obviously characterized COPD as severe. So, next. This is the common grading, which is the scale, the Medical Research Council scale, modified MRC grade. You see from 0 to 4, 0 if one gets breathlessness with strenuous exercise, and then 1 is when one gets breathless when hurrying on the level ground or walking up a slight hill, and 2 is one can walk slower than people of the same age, but still can walk and have to stop in between, etc. But grade 3 and 4 means one has to stop to take breath, you see, after walking about 100 yards or after a few minutes. And of course, grade 4 is one is too breathless, sometimes even to leave the house or the bed, you see. Next, please. So what are the treatment principles? The most important is to remove the exposure or the trigger as far as possible. For example, smoking is the most important causative factor. If patient is a smoker, quitting smoking is very important. And this has to be reinforced and checked at every visit of the patient to the doctor. You see. Other contributory risk factors should also be removed. For example, passive smoking exposure is, and other, if kind of domestic smoke, combustion or kind of outdoor combustion of dry residue of plants and so on. That has to be controlled as far as possible. Otherwise, inhaled drugs are the mainstay of pharmacotherapy, and the initiation and modulation of treatment based on severity assessment is done. Empiric treatment may be started based on clinical parameters alone if spirometry is delayed. It may not be immediately possible or always possible to do spirometry. So one can start treatment of COPD based on symptomatologies. And once treatment is optimized, then the schedule should be followed, and every 3 to 6 months, it should be kind of reviewed at revisit for mild to moderate disease, or even earlier, shorter period, 1 to 3 months for severe disease. Patient is to be educated properly. Rehabilitation is very important, which includes patient education and other things. Other factors like exercises, nutrition, and so on. And inhaler technique is also very crucial, you see, because both for asthma and COPD, inhalational treatment determines the success of treatment, you see. And if patient is not using inhalers correctly, then the treatment failure may be entirely due to the inadequate procedure rather than to the drug control. So if symptoms remain poorly controlled despite treatment optimization, or if complications develop, then patient should be referred to higher centers. Next, please. So this is the kind of a summary of the pharmacotherapy. Depending on the mild, moderate, and severe COPD. If it is mild COPD, as one can see on the extreme left side, you see, then simple inhaler, like simple symptomatic treatment like LABAs, which we call as this SABAs, sorry, levosolbutamol, etc., should be given 2 puffs immediately, and SOS as and when required, you see. If the symptoms are persistent, then one can add a kind of long-acting agent as well, either combination of both solbutamol or tiotropium, salmeterol, and so many drugs. I'm not going into the details here, but by and large, the bronchodilator agonists are given. If the bronchodilator, the beta agonists. And if it is moderate, then we start with the tiotropium from the very beginning, which is a long-acting muscarinic acid. And one can use the SABAs, the levosolbutamol, as and when required. And if persistent symptoms are used there, you see, then one can add low-dose methyl xanthines, oral, you see. Well, oral drugs are very popular in this country. We cannot totally omit them, but they should be reserved only for moderate or severe COPD and only as accompaniments, you see. The primary treatment remains the inhalational treatment. And of course, for severe COPD, the other inhalers, besides the LAMAs, one can add the inhaled corticosteroids, etc. I'm not going to the actual, these days, especially chest physicians use a lot of kind of other parameters also to determine the treatment, you see, and dividing in the patients into different categories, A, B, and E. Those should be left to the specialist and for higher centers. But at primary and sometimes even at secondary care level, I think it is better to stick to the baseline treatments. You see, if there is inadequate response or onset of new complication, or there is suspicion of alternate diagnosis, then patient is to be referred to a specialist or a higher center. Next. One of the important problem with COPD is the exacerbations, you see. In fact, most of the disease burden as well as the economic burden, hospitalizations are attributed to the exacerbations. They are sometimes, if they are very severe, they can be fatal and require very intensive treatment, in which I'm sure Dr. Dhruv is going to discuss in the next talk. Mild exacerbation, of course, is just defined as worsening of the patient's respiratory symptoms that are beyond normal day-to-day variation and that lead to a change in medication. So one can increase the dosages of the drugs or add the other bronchodilator, combination bronchodilators, or sometimes oral bronchodilators like theophylline in addition to the inhalational treatment. And most of these patients with mild exacerbation should do well, you see. And assess if patient can be managed on outpatient basis, you see, if it is mild or needs hospitalization for severe. So this is very important to assess because that would determine the control of disease. When do we call a severe exacerbation? When the respiratory rate is high, more than 30 per minute, heart rate is high, systolic blood pressure is falling less than 90 millimeters. When there is cyanosis or hypoxia, SpO2 is less than 90%, or there are paradoxical respiratory movements. And in severe cases, it could be altered sensorium, strict CO2 retention can occur and cause all these problems, you see. Or there is presence of severe comorbid conditions, cardiac conditions in particular, you see, or there is severe uncontrolled diabetes and so on. So all these things require hospitalization. Next, please. I have already said it partly the previous slide. Yes, for mild, you can just do some kind of readjustment of treatments and increase the dose or frequency. And a short course of antibiotics may be required here. Amoxicillin, for example, 500 milligram thrice a day, or azithromycin or doxycycline, etc. As Dr. Khilnani has said in the very beginning, for respiratory infection, we avoid the quinolones in particular because of the risk of tuberculosis. Sometimes oral prednisolone for 5 days is given if for an acute exacerbation, if the bronchodilator therapy alone is not enough. But for severe exacerbations in the presence of signs or symptoms and laboratory criteria, which I have said earlier, the patient should be referred to a hospital. Next, please. So these are what are called the red flag signs you see, or the danger signs: the altered sensorium, low SpO2 despite therapy in particular, heart rate more than 110 despite therapy, systolic blood pressure falling, and other cardiac comorbid conditions like arrhythmias, cardiac failure, poorly controlled diabetes, or other system diseases. Next, please. So if any danger sign is present, then patient is to be referred to a higher center, and oxygen should be continued during transfer because that is the most important supportive therapy for these patients. And nebulization should be also ensured during transfer before it should be given, so that patient is as comfortable as possible. All these parameters depend upon the place where you are referring to and from where you are referring to, and other factors. And schedule follow-up at primary care level 1 week after discharge from the hospital, so that the patient goes back to the same physician who has been treating earlier, you see, so that he does not lose the patient, as well as the patient also does not lose the primary place of his treatment. Next, please. So just briefly, 1 or 2 minutes for hospitalization. So hospital admission is done whenever there are severe symptoms or there is sudden worsening of resting dyspnea, fall in oxygen saturation, and other failure to respond to initial treatment or comorbidity. And patient is discharged from the hospital when there is normalization of clinical and laboratory data, and patient goes back to the initial treatment, maybe some supplementary treatment in addition to that, you see, and the patient is able to follow maintenance therapy. I think that is very important to ensure, because after an exacerbation, I am sure the patient also learns his lesson, you see, not to play with the treatment and so on. Next, please. Next. I think there is some. Is that all? Is there any next slide, please?
Yes, sir. And
Okay, so I think that's by and large, that's all what I wanted to say. Maybe 1 or 2 slides were more, though, but otherwise, I think the main issue is that the COPD should be suspected early, should be differentiated from asthma and other causes of breathlessness, and evaluation and long-term treatment.
please share, sir, take home message.
Yeah, that is what I'm trying to say. The asthma and COPD are two different disorders that should be remembered, although they may present similarly in some ways. There are some overlapping features, but otherwise they are two distinct disorders, you see. And evaluation and long-term treatment at primary care level should be based on standard treatment guidelines, which we have discussed partly. Stepwise approach is required. Removal of risk factors is very essential, especially smoking. And inhaled route is the preferred delivery format for the drugs. And multiple inhalers are available, and the market today is flooded with different kind of inhalers, single inhaler, kind of the double drug inhalers and triple drug inhalers and so on. But most important is a correct inhalational technique, I think, was that is uh, the problem with the inhalation technique is the most important cause of inadequate treatment, you see. Treatment should be individualized depending upon the patient and should be properly trained. You see, the patient should be properly trained. Regular disease monitoring is essential, and early recognition of exacerbation is important because exacerbations determine the prognosis of COPD. So control of exacerbation is most important. The more the exacerbations, the more the problems, the morbidity, as well as the mortality is high from exacerbation. Well, thank you very much. I'm sorry for this kind of delays. Thank you.
Thank you, sir. Sorry for the inconvenience. Deeply regretted because of network issue. I'm not able to fix the slides. Very, very sorry. Now I request all the participants to please scan the feedback. I'm just sharing before starting the next session by Dr. Dhruv, sir. So
Shraddha, you can put the feedback in the chat box, but let Dr. Dhruv's session be starting.
okay. Now I request Professor Dr. Dhruv Chaudhary, sir. He is a professor from Pandit Bhagat Dayal Sharma Postgraduate Institute of Medical Science, Rohtak. He will be speaking on standard treatment workflow of respiratory failure. Please, sir.
Good evening, everybody. I hope the slides are visible.
Yes, sir.
Thank you, Shraddha, and thank you for helping in making these slides. And thank you, Dr. Ashok Grover and ICMR, and my revered teacher, Professor S.K. Jandal, Dr. Ashutosh, Dr. Khilnani, and all other colleagues. As Sir said it, and also Dr. Ashutosh, that ICMR has been in it for making standard treatment workflows so that we have a uniformity of care across throughout the country as far as common diseases is concerned. And that's what we had come up with it. And as he's pointed out, nearly 23 different STWs have been formed. And I think which is relevant to us is actually also for the pulmonary, for the tuberculosis as well. And I had the privilege to work with her as well as Professor Ashutosh Aggarwal. Now let's come down to, we have all listened to Professor Khilnani, Professor Ashutosh, and Professor Jindal. So by and large, most of these disorders have been, in one way or the other form, have been there. But most important is looking at it, identifying clinically at the level of primary care or even to an extent at secondary care, the respiratory failure. I think it is very fundamental. And what is very important is that the respiratory failures, which we have put it up here, are primarily dealing with the respiratory diseases. We are not covering in it the respiratory failure, which can happen because of the ventilatory causes, like you may have a traumatic spinal injury. You may also have some of them at the demyelinating disorders, vascular disorders, or maybe because of snake bite or neuromuscular black, etc. So here our focus primarily in this STW primarily has been with the respiratory failure leading by the respiratory disorders. Therefore, the symptom complex becomes an important, and this is just going to be the repetition to an extent, or what may say, not even the repetition, summation of what has been discussed by Professor Khilnani, Dr. Ashutosh, and Professor Jindal as well. So when we talk in terms of one of the very common features of a respiratory failure, obviously we will define it up when there is alterations in oxygenation or there is an elevation of carbon dioxide. And obviously we all seen it, the respiratory failure pandemic, practically because of the pandemic of COVID. And that would very well explain. And in these cases, symptoms dominantly which have been coming to us have been the shortness of a breath. And in this case, if you see it, when you see it, the shortness of breath will be when person starts feeling little out of breath, which probably they were not aware of it. You may or may not have a wheezing or a chest tightness. If you do have a wheezing or a chest tightness, then probably what we see in these cases is that likely to be airway disorders. So in the airway disorders, we usually commonly will have chest tightness like acute severe asthma. Even in the COPD case, you will have a worsening of a cough and a shortness of breath and wheezing. In other words, a person who was otherwise asymptomatic or had a breathlessness because of any chronic lung disorder suddenly becomes worsened and person finds it difficult to talk in sentences, person finds difficult to lie down and have a breathlessness. That means there is something going wrong. So what do you look at that point of time? So it can give you an idea that the major function of respiratory system to cause oxygenation adequate and to remove carbon dioxide probably is suffering, and that's leading ultimately on to symptoms. So that means either there is a exchange failure of the gases, or there could be a challenges which are coming up because of increased work of breathing, because of increased airway obstruction, which you have seen it, which you have heard from the experts in terms of your asthma and COPD. You can have in these patients markedly increased respiratory rate. Normal respiratory rate usually is between 12 to 16, but here on an average, we tend to see the respiratory rate going more than 20, 24. And obviously, when you are not having inadequate oxygenation, or you are having a little more of a carbon, you will be restless. The person is not going to be at ease with himself or herself. And there will be, because there are sympathetic mechanisms there. So persons will be markedly anxious. There is going to be sweating, and there will be moist skin and moist your palms and soles. And if it goes further, extend the severity goes further, then the confusion is there. So what you see commonly is starting from increase in respiratory rate, which is the most important clinical sign. Unfortunately, what we see is people don't look at it. Pulse rate, BP, everybody sees. Please give due emphasis to that. And then along with it, you will see presence of restlessness, anxiety, and confusion. Along with it, which is very important clinical sign, is that there is an increased work of breathing, though it is not written. And an increased work of breathing, you will see that the persons, when they are feeling breathlessness, along with it, you will find that the nasal flaring is there, which is AIIMS. Similarly, accessory muscles of work of respiration will be working, and there could be an indrain of respiratory or the chest wall, which can all be signs of work of breathing, and we need to take in account. And when you can have an alternate movement of the diaphragm and the chest wall, we call it as a respiratory alterance, that can also be seen. So if you find there is a marked hypoxemia, or there is a marked increase in carbon dioxide, which is called as a hypercapnia or hypocarbia, you may have a seizures or an epileptic fit. When you see and evaluate these patients, when oxygen levels are low, there could be cyanosis. Asterixis is actually when you ask the person to raise their hands, they will have jerky movements which will come up, or even the body and the trunk can also have a jerky movement. And obviously, when you have an inadequate oxygen or excess of carbon dioxide, you can also affect the cardiac functions or the heart functions, which will lead to change in the character of the heartbeat. So there can be a tachycardia. Along with tachycardia, there could be multiple ectopics. We can call them as a multifocal atrial tachycardia that you can only identify in ECG. You may have an irregularity of rhythm. So be careful about it, that either we are finding ectopic activity, or alternatively, there could also be an atrial fibrillation or multifocal atrial tachycardia. So it is very, very important that look for when you find a hypercapnia, headache, etc. Now, in patients of COPD, which Professor Jindal talked about it, you will see people will be relatively blue. And that's one of the blue bloaters. They will be a little more obese. And the reason for this is because there is an increased amount of hemoglobin, plus because there is an increased amount of carbon dioxide. This combination will be there, which tends to be dominant subtype of COPD, which Sir has talked about, is called as chronic bronchitis phenotype. On the other hand, people, when they are thin, there's a marked inspiratory muscles working that you can see it in patients of emphysema. Whereas in patients who have got this hypocapnia, like usually you have a sympathetic activity, carbon dioxide, which is there, can lead to dilatation of blood vessels, which can lead to very significant headache. You can also have a bounding pulse with the sweaty palms, and that is where you see flaps. And if you are good in seeing the fundi, you can the fundus in the eyes, then probably you can also see papilledema. And quite often we see when you give an oxygen, uncontrolled, I will be coming to that little later, a conscious patient may become unconscious because of the type and the way the oxygen is used. So that is very important, how to use oxygenation in these cases. Now let's look at the hypoxemia. Hypoxemia is defined when your oxygen levels are less than 60 partial pressure, but because at the peripheries, we may not have a facility for blood gases, and that is true for most of our district hospitals, and also true for majority of our clinical practitioners in the who are sitting in the OPDs. So the best tool for us is a SpO2, that is a pulse oximeter. All of you have become familiar with it, or all of us are familiar with it because of the pandemic. Now, pulse oximeter will give you, or when you put it on the fingers, that can give you an idea what is the level of saturation. Normally, we tend to put it on index finger, but ideally should be put it nearly on the middle finger, where it can have a dual supply, can give a much more reliable. So whenever you put a pulse oximeter, what is extremely important is wait. Wait for a minute. Once that thing gets stabilized, see for it. But before you put pulse oximeter, ensure it that there is the hands are the moist, the pulses are present, because if you find person is in a shock, please look at the blood pressure. If the person is which can be monitored at the level of CHCs, PHCs, even at the level of RDs or in the clinics. So please look at that. If the blood pressure is adequate, then probably pulse oximetry can give us a very good amount of an idea. Normally, we take SpO2 hypoxemia less than 90%, but during COVID, to identify early, we went up to 94%. So if you find there's no reason a person is breathless, person is having a fast respiratory rate, please do look at if SpO2 is less than 94, you need to be worried, and less than 90% is definitive evidence of person having acute respiratory failure secondary to hypoxemia. For carbon dioxide, you need to do a blood gases, or if some of those who have the facilities of non-invasive, then you need to look at side stream capnometry. But short of that, it is the SpO2 which gives us a guide. Now, when you start looking at it, obviously there is a differential diagnosis. Hypoxemia occurs because of the inadequate oxygenation exchange. That means when your lungs lose that capacity to exchange oxygen, that will happen when the lungs are full of water. That is called as edema. And this, if it is a non-cardiac cause, then it is called as a non-cardiogenic edema. When it is a cardiac cause, you call it as a cardiogenic edema, which otherwise we call as a heart failure or acute left ventricle failure. And these patients will be definitely breathlessness when they lie down. They feel very uncomfortable and sit down, and that is called as orthopnea. They may also have an evidence of an underlying disease, which can be a long-standing history of the valve disease, or alternately, they may have a coronary artery disease where they may complain also when acute setting angina or acute coronary syndrome when chest pain is important. Wheezing is a later feature in these patients, and you will see person will be breathing fast, will be breathing hard, and along with it, there will be a marked sweating and perspiration. And when you see in these patients, there will be tachycardia. And when I say pulsus alterans, it means alternate pulse will be strong and weak, and there could be a fast pulse rate. There could be whenever there is a flooding of the lungs, you can have a frothy sputum because of the presence of the RBCs. It become pink frothy sputum. These patients will be cyanosed, peripheries will be calmer, colder, whereas in patients of COPD exacerbation, peripheries will be relatively warmer. And in these cases, if you have a right heart dysfunction, along with it, you may have a distended neck veins. That can be these are the classical features. And when you auscultate it, bilateral extensive pulmonary edema from the bases you will see, and gradually from the bases it can go to the top, which we call as a CALIP 1, 2, or 3, depending upon the severity. But most important is a fine and inspiratory crackles gradually going and extending upwards. And therefore, obviously, can be polyphonic wheeze, which can happen. And you put your stethoscope on the heart, you will see there will be marked tachycardia or sometimes additional sounds, which we call as a gallop rhythm. They may be there. Similarly, in the valve cases, you will be able to auscultate the murmurs. Now, when you come to the pneumonia LRTI, Professor Khilnani explained it in a very well way. And what you are required in this case, the triad is which we look at it. And the triad means you will have a fever, you will have a cough, and along with you have an expectoration and pain chest, which will pleuritic may add up. So if you have a fever, you have a pain chest, you have a cough, which is purulent, or resolution time, you may have a rusty sputum, which he described. So that is the triad. Classically, we look at it. Then you do a severity assessment. For the severity assessment, these signs becomes extremely important. And when you say tachypnea, it means respiratory rate. He did speak about anybody who has a respiratory rate more than 24, heart rate more than 100. You can auscultate not only crackles, you can also change in the breath sounds from vesicular become to bronchovesicular, or they become a tubular bronchial breath sounds. And along with it, you will have a crackles which are there, which tend to become far more pronounced during the resolution phase, and there will be wheezing along with it. Hypoxemia is a rule in these cases when you find out that there is a large lobar consolidation. Pleuritic pain chest happens when there is a pleural involvement, and they may have a pneumonic effusion. When you find there's a decreased breath and sound, you will confirm later on with X-ray chest. So radiology, when you suspect it, you do an X-ray chest and you find clinically that this is pneumonia. Similarly, in heart failure, you will see the heart is large. Another thing, though it has not been added, but that again is a pneumonia-like picture, which you saw in COVID, which is a viral pneumonia, predominantly hypoxemia, multilobar settings happening up. And in these cases, what you will see is that there is a marked hypoxemia tachycardia, but there will not be any clinical evidence of heart failure. You called it as a non-cardiac pulmonary edema, or you may, let's say, because I'm talking about LRTI is written here, so viruses are the important cause besides bacterial pneumonia like COVID and influenza. And radiology can give you a fairly good amount of an idea. If you have all extensive lobes, then it is suggestive more of a COVID, but more higher shadows predominantly towards it, then that will tell you more like influenza. But this is, again, relatively in immune competent people. Now, if you find person has come to you with a sudden onset shortness of breath, it may be either a pleuritic severe pain or maybe a central constriction pain. You can also see that there is a calf pain or a swelling in the legs, and the X-ray chest is normal. Please do think about it. If somebody has a breathlessness, you are not finding a cause, there's an unexplained tachycardia, please think in terms of pulmonary embolism. So the commonest abnormality you will see is tachycardia. And on auscultation, you may find tachycardia only, and sometimes you will see if there's a massive embolism, blood pressure may fall, and the veins may be prominent. Acute asthma, Dr. Ashutosh and Professor Jindal has talked about it. The most important thing we always talk in terms of it, there is usually a history of asthma from the childhood or the young adult. And in these cases, in asthma, breath sounds are very crisp, but it's only in acute severe asthma, the breath sound starts falling down, and a silent chest is a very ominous sign in acute asthma. Besides chest tightness and cough, person will be having accessory muscles, maybe breathing very hard, very fast, and they will be finding accessory muscles working. So you can have a tachypnea, you can have a tachycardia, and gradually you will see a fall in the SpO2, which may happen in these cases. On the other end, when you took in the COPD, it is in the elderly people, or you tend to see beyond 40. But some of these people who have a chronic respiratory disorder like bronchiectasis, or you may having a people having a bronchiolitis, etc. in the childhood, they may have sometimes a confusion. But most important thing is that there will be a history of smoking. Tuberculosis now we are identifying as an important risk factor. All of you see these number of cases in the periphery. But most important is person have been symptomatic, gradual worsening, then there is an increase with this cough. There's an increased sputum production, which may become purulent over a time, and the person feels breathlessness, and that gradually, like he was able to do his normal work, starts becoming restless and can't do a work. And if they develop a respiratory failure along with it, you will find a significant evidence of cyanosis, that there may be a little bit of polycythemia, and accessory muscles will be working. And if these CO2 levels go up, you will see a flaps, confusion, and these patients may develop, end of the day, edema, papilledema, if you have the ability or you have the availability of fundoscopes with you. Short of that, sometimes there is a confusion between AECOPD and heart failure, especially in elderly. But most important is a past history of COPD most of the time is there. And by and large, breath sounds in these patients are always low. Wheezing may not be as prominent as you see in acute asthma, but most of the time, relatively calm chest with wheezing and increased production, give you a diagnosis, and if a hypercarbia is there, already we have discussed number of times these signs. Now, bronchiolitis is another thing. Here again, commonly you will see what is the sign of bronchioles is a small one, like after 20-22 divisions, when you start doing it, they may not have a cartilage with them. And in these cases, you will see that it is the wheezing which is the dominant with breathlessness, and commonly we tend to see in children. RSV is a prime example in both elderly as well as in the children. So patients will again, the features will be resembling something that of asthma, marked wheezing, respiratory distress, and flare is going to be there. And in these cases, extremes, you can see paradoxical breathing. And again, crepitations, rattling sounds, which get cleared usually with expectoration, is commonly seen in these patients. Finally, let's come down to the diagnosis, treatment, and what we are seeing it on. We've already talked about the diagnostics in it. What is the therapeutics in it? And most important part, I said, when you define respiratory failure, what we say, it is the inability of the system to maintain the gas exchange. So the net result is hypoxemia, which is low oxygen, and hypocarbia, which is low ventilation, leading on to carbon dioxide elevation. Oxygen therapy, all of them require it. But most important, and the careful you need to be in acute exacerbation of COPD. There you need to be very careful about two things: how much oxygen to be given and which device to be used. So if you are suspecting AECOPD, the device to be used with you is a Venturi mask. If you do not have the availability of a Venturi mask, then probably you may use 1 or 2 liters of oxygen, one. Secondly, as we have written, bronchodilators, never ever do nebulization with oxygen in patients of AECOPD, acute exacerbation of COPD. On the other hand, in patients of asthma, there's no issues. We can always use oxygen liberally. We can use oxygen also if you look at various guidelines, which we have also evidence put into it. There you can use oxygen for nebulization if you don't have availability. SpO2 is very important. There you maintain around 94, 96. Whereas in patients of ACOPD, we do not overdo in any chronic lung disease. We try to keep it around 88 plus minus 2%. That is good enough. And so that 88 to 92, 90 plus minus 2, we don't go beyond that. And patient starts feeling better. How you do is that assessment. Patients become a little better in terms of breathing. Pattern of the hardened breathing becomes a little gentler. Respiratory rate falls down. Heart rate starts settling down. And patient feels at ease with herself or himself. Diuretics are only needed and required if you are suspecting that somebody has got acute heart failure. There we use furosemide or torsemide, whichever is available. In rest, usually we don't use it. Now, the bronchodilator therapy, the mainstream for us continues to be short-acting beta agonist and the short-acting muscarinic antagonist. And they are basically salbutamol, which is also called as an albuterol. And you are finding some variants of it today in the market. That is what is called as a levosalbutamol, which is the active one. So that you can use along with ipratropium in acute asthma. You probably can use continuous nebulization in patients of acute asthma, or you may use intermittent, but data shows is in favor of continuous use. And along with it, intermittently, you can use SAMAs in these cases. And if there is an ARI or bronchiolitis, probably at that again place, you can use a combination of SAMA and SAMA if we are finding a lot of wheeze, breathlessness, etc. Antibiotics are not required in heart failure or asthma. Most of the exacerbations tends to be sudden exposure to allergens or to viruses. In patients of AE COPD, what we need to look at it, that quite often when the sputum is purulent, secondary infections commonly are the viruses, followed by they can have a bacterial infections. In these cases, we have looked at it. We need to identify the risk factor for the Pseudomonas, because 1/3 of the cases today we know of COPD as a bronchiectasis or bronchiectasis. Larger ones, dilatation is bronchiectasis. Smaller one is a bronchiectasis. And if you can exclude TB, then you can use quinolones. If you have a doubt of a TB, please don't use levofloxacin or moxifloxacin. At that point of time, then third generation cephalosporin, or preferably if Pseudomonas risk factor, as I told, structural lung disease is there, there you may use piperacillin or piperacillin or ceftazidime with avibactam or cefpime. On the other hand, if you like influenza, now this is the season now for coming for the influenza, especially now the monsoon time. So this is another spot we see, oseltamivir, preferably within first 48 hours. You can today make a positive diagnosis. It's not that from the PHCs or CHCs only send the samples for COVID, but what is very important, please ensure it that you'll tell your lab, and it will be request to the directorates of all the states to ensure that influenza is checked along with it, because it is treatable if we start in 48 hours. Beyond 48 hours, its use is plus minus. If you have a pneumonia, as already explained to you, to all of you by Professor Khilnani, if it is a mild to moderate case, usually they will be a curb 65. If you look at it, first and second one mild to moderate. Here we tend to use amoxicillin or ceftriaxone. But today some data is suggesting in this country, because of the resistance, probably we prefer a beta-lactam inhibitors, that is amoxicillin plus clavulanic acid or ceftriaxone. Severe cases, again, the same drugs will be used injectable, but we are now with the molecular things, we are finding it up. Nearly 1/3 patient with AIDS viruses, nearly 1/3 of our cases have atypical organism. There you can use azithromycin or doxycycline. Injectable are basically kept for the severe diseases who are admitted in the intensive care unit. So you need to prognosticate in these through the curve 65 already described. I will not go into it. Corticoids are not usually required. It is a drug of choice to reduce inflammation besides Lama-Saba in patients, Saba-Sama in patients of acute asthma. And this is a class 1 indication also for acute exacerbations of obstructive pulmonary disease. In fact, said the ARI, though we have written, yes, we need to look at what is causing it. And only then when you're finding there's a significant evidence of inflammation not responding, you may use corticoids. Whereas in patients of pneumonia, there's a lot of debate about it, but we all know severest form of pneumonia where you're finding hypotension, or we are finding CRP levels, if it can be checked, which is more than 150 milligrams, probably you may use for a short point of time for 4 to 5 days in methylprednisolone. In the viral fevers, if you see in the COVID, if we are suspecting in influenza, steroids are big no, capital no. On the other hand, if you're suspecting like COVID-like illness in these patients, because it's the second week of illness. In the first week of illness of any viral illnesses, we don't use steroids. But in the second week of illness, if the deterioration is there, where COVID is suspicion, corticoids not more than 6 milligram dexamethasone has to be used. Low molecular weight, heparin is only required in the severest of the severest cases, not otherwise, except when you suspect pulmonary embolism, you have a clinical evidence of DVT, you have a very strong suspicion of pulmonary embolism, then you can put these patients on.
Excuse me, sir. So we have to move on a faster note as we have to finish.
I'm finished. This is the last slide here. It is finished.
Yes.
As far as the
Yes.
referral is concerned, Obviously, no relief or need to mechanical vent. Whenever you suspect the patient's not doing well, becoming drowsy, the rates are not settling down. That is the time when you will see these and send these patients for higher centers. With this, I finish off my slides. Thank you very much. These are the only 3 slides.
Yeah, thank you so much, sir. Thank you for the wonderful explanations and discussion on standard treatment workflow. Now I request Dr. Pankaj Yadav, sir, to give the closing remarks and vote of thanks on behalf of Dr. Umesh Devappa Surangi, sir, and Dr. Avinash Thilia, sir. He is busy. So please welcome Dr. Pankaj Yadav, sir, from DGHS.
Yeah, thank you, Shraddha. I will like to begin with the greetings first. So, greetings from National Program for Prevention and Control of Non-Communicable Diseases to all the panel of experts we have here today, the state nodal officers, NCD district nodal officers, and NCD medical officers across the country, and faculty from various medical colleges, along with the ICMR STW team who joined the webinar. So, we appreciate your contribution today in the national webinar for dissemination of standard treatment workflows on respiratory disorder developed by the ICMR. Today we have with this the renowned expert on the chronic respiratory diseases sharing with us the standard treatment workflows on commonly encountered clinical conditions in acute respiratory infection, asthma, and COPD. So the standard of care is a foundational of the safe, ethical, and effective delivery of the healthcare. It ensures that patients are treated appropriately, providers are supported in the decision making, and the overall quality of the care is continually upheld. So STWs are critical tool for the state nodal officers under NPNCD. They ensure standardized and the high quality care to facilitate effective training support, monitoring and evaluation, and enable efficient resource management and rapid implementation of health intervention. Their adoption is essential for the sources of NP-NCD program at a grassroots level and for improving health outcome related to non-communicable diseases across India. This STW webinar will ensure that healthcare providers at all levels, primary, secondary, and tertiary, adhere to evidence-based uniform protocols for diagnosing and managing these respiratory disorders. This reduces variability in patient management and promotes high uniform standard of care across the country. These workflows are concise, one-page, easy to follow, document, or mobile application resources, enabling quick references and decision-making, especially in high-volume settings where time per patient is limited. This structure helps maintain treatment adherence, monitor complications, and ensure continuum of care for all which are emphasized in the NPNCD operation guidelines. So some of the key advantages of STWs like standardized care for across facilitate and ensure quality and uniformity. Provide content for workforce training and build capacity in the state to improve the treatment and medical services. It provides a benchmark for appropriate treatment protocols also, and ensure uniformity and consistency in patient care across providers and institutions. Last but not the least, but resource planning becomes easy for guiding procurement and logistic also from the STW implementation and comes if it comes in the clinical practices. So with NCD accounting for approximately 63% of all deaths in India, their prevalence rising rapidly, especially in the rural area, and widespread adoption is essential for scaling up effective prevention, early detection and management strategy, ultimately reducing morbidity, mortality, and financial burden of families and the health system. So given the variable availability of specialists and the spread of NCD into the rural and underserved areas, the STWs enable non-specialist providers to manage common condition effectively. This supports the NPNCD goal of decentralization NCD care and reducing the unnecessary referral to the higher centers. So we are very thankful to ICMR team led by Dr. Ashu Grover, Scientist G, and Delivery Heads Research for finally shaping up these standard treatment workflows and taking this forward in the form of webinars. We also are thankful to Professor Dr. Sunita Sharma, DGHS, Ministry of Health and Family Welfare, Government of India. We also thankful to Dr. Swasticharan sir, DDG NCD and Director EMR, Ministry of Health and Family Welfare, Government of India, for their continued support and guidance to make the webinar successful. We also like to thank our eminent speaker of today's webinar, Dr. Khilnani, Chairman PSRI, Dr. Ashutosh Aggarwal, PGIMR Chandigarh, Dr. Surender K. Jindal sir, and Dr. Dhruv Chaudhary from PGIMS Rohtak. Along with that, we also thank to Professor Dr. Umesh Devappa, ADG, DGHS, Ministry of Health and Family Welfare, and Dr. Avinash, DADG, NCD from Ministry of Health and Family Welfare. So thank you everyone for making this webinar a great success. Thank you all. Thank you everyone. Thank you Shraddha and thank you SMA team. Thank you everyone.
Thank you, sir.
Thank you everyone. I really thank from bottom of my heart to all my experts, my teachers, Dr. Dhruv, Dr. Jindal, Dr. Ashutosh, and Dr. Khilnani, who had really made the effort. And today is the day, sir, the ministry is taking for dissemination to all the medical officers in the country, sir. So thank you, Pankaj, thank you, Umesh, and Dr. Swasticharan, everyone. Thank you.
Thank you, ma'am. All the attendees, I request to please scan these scan codes displaying and please mark your presence and please fill the feedback form. Although we actually concluded the webinar and the question ask session will be left, I appreciate Dr. Ashutosh Aggarwal sir for responding the messages of all the attendees for their questions, and thank you so much, sir. And if anybody has any question, they may ask.
Okay, thank you. I will be leaving. I have to boarding. Thank you.
Thank you, ma'am. Thank you so much, ma'am. Yes, sir. Nareen Nath Soren, sir. Please unmute yourself. Nareen, sir, please unmute yourself and ask your questions if you have. I'll make you panelist simple.
Thank you. Hello?
Yes, sir. Yes, sir.
Audible?
We can. Yes, sir. Yes, sir. You're audible.
I am speaking from West Bengal, Dachin Dinajpur. In COPD or asthma at early, can we add steroid?
Sir, you mean inhaled steroid or oral steroid?
Oral steroid, sir.
So generally for asthma or for COPD, we would not advocate oral medicines, least of all oral steroids. So for asthma, the mainstay of treatment will remain inhaled steroids. Only in extremely severe cases where inhaled therapy, even at ceiling doses, does not provide the required benefit, and while you are waiting for a referral or for evaluation of other diagnosis, you might consider low dose steroids in a maintenance phase. But generally, I personally would tend to avoid it because it is associated with substantial side effects and it may mask a separate diagnosis if it is not evaluated. Similarly for
Thank you, sir.
COPD. So steroids are not a panacea in any sense, either for asthma or for COPD. But you can give them during the phases of acute exacerbations where oral steroids are recommended in a low dose of 0.5 mg per kg per day for 5 to 7 days.
Okay, sir. Thank you, sir. Thank you, sir.
Thank you, sir. I request all the attendees to please scan the scan code display and please mark your presence and fill the feedback form. Thank you, Dr. Ashutosh ma'am. Thank you, Dr. Sunita Sharma ma'am, Swasticharan sir, Dr. Khilnani sir, Ashutosh Aggarwal sir, Surendra K. Jindal sir, Dr. Dhruv Chaudhary sir for participating as a speaker in this webinar and taking out time. Thank you so much, sir, for your valuable support. Good day, sir.
Thank you. Thank you.
More